And without too much further ado, it looks like we got a dozen. We're up there now finally, and they'll trickle in as time goes on. Mark, Mark Stern shouldn't need introductions. I have known Mark for the better part of 20 years. Mark will tell you all about his own perhaps intimate connection with this topic, if you're not aware of it already. And what I can tell you about hunger strikes is that Mark has probably learned the hard way better than any of us how to manage hunger strikes. And I'm thrilled that he agreed to do this talk today. And I've been looking forward to it for a long time. Mark, why don't you give yourself better introductions? I know you're working at University of Washington and you're a private consultant doing a lot of work all over.
Sure. Well, good afternoon or evening or morning to everybody.
Wherever we are,
yeah, wherever you are. And if you, so my name is Mark Stern. I'm a correctional physician and I'm internal medicine. I used to be the medical director for the Washington State Department of Corrections, and I was a jail medical director back in New York. And these days do a bunch of odd jobs, I guess I'll say, and have had some good and bad encounters with hunger strikes. So a couple of housekeeping things for us. First of all, I don't use the chat function. So if you want to talk to yourself, put something in the chat and read it, but I won't be reading it. We're a small enough group that just unmute yourself and say it out loud. If you can put on your video, if you are decently clad and are comfortable, so that I can see you, because this is more of a class than a webinar, and it's important to be able to see faces and body language and see when I've said something really stupid and Charles goes, huh, what did he just say? And you may want to grab a pen and paper to take notes, because there's not a whole lot of slides, and if there's something that we come up with that you want to remember, you probably best ought to write it down. So in that note, and Michael, I'll tell you that we have a great picture, I think, of your ceiling, if that was your intention, but can't see you.
Really? I'm seeing myself on my own.
Not you, Dututu in Florida.
Oh, okay.
Oh. Oh, I see. It's a really, really dark. There we go. Your hallway. So he's going to a better place. So let me just start with a question for you guys. And I know it's going to sound like a stupid question, but it really will take us into an interesting discussion. So how do we define what is a hunger strike? And if nobody knows the answer to this question, then I'm hanging up and we're ending.
Okay, let me give a shot at it.
All right.
I think a hunger strike is a person who, for an unknown reason and possibly a known reason, refuses to eat for a prolonged period of time. That raises the question, the definition of prolonged period of time. And I'm going to throw an arbitrary number of days. I'm going to say 3 days. For social, political, or other personal reasons.
Okay. Any additions to that, or dissenting views?
Yes.
Oh,
yeah.
okay. I love it.
Yeah. Here's the problem. I have a fellow who is hyper religious, and he thinks that if he can fast for 40 days, he will achieve immortality. He's absolutely convinced of that. He's been in the mental health hospital in the state of Maine and explained that to them. And for that purpose, he is in training. And he started out with 4 days of fasting, and then he gorges himself on food, requesting protein drinks, what have you, in order to get to 5 days. And now he's at 9 days. And we have decided on the medical side not to give him any Ensure or anything like that. We've had endless discussions with him, including the psychiatric folks. And they say that he's delusional, but really not so crazy. He's just, it's a religious fervor that he has. And I don't know if that's a hunger strike. I guess it is. It's a purposeful, timed, segmental hunger strike.
Are other thoughts?
I
Interesting.
would say that a hunger strike really is only, in my opinion, it is to not take in enough nutrition long enough so that you develop some physiologic evidence. And that
So
could be 3 days, it could be 5 days, it could be 7 days. I mean, I had a guy in Illinois DOC who was on a hunger strike for 300 days.
for how many?
300,
Yeah,
but he
Okay.
was drinking, obviously.
he was drinking, he was taking the protein, but he refused to eat anything. And so as far as I can tell, he wasn't physiologically harmed, he was just misbehaving.
So at your respective facilities, does what does your policy say about the definition of a hunger strike? Anybody?
Yeah, I work for the Federal Bureau of Prisons, and we have a definition of 72 hours or 9 missed meals. And it's either they've said or they say they're on a hunger strike. If they say they're on a hunger strike, it's basically effective immediately. Or if they miss 9 meals, then consecutively, then they're on a hunger strike, whether they admit to it or not.
Okay.
And so that's the rule we use.
So let's take John's rule for, well, it's not John's, but BOP's rule, because that's a pretty common one. What would you propose is the problem with that definition from a physiologic standpoint?
Eating
Well, if
one
you're
meal
drinking-
every 3 days.
Say that again, Mike?
If they're eating one meal every 3 days because they want to slip under the radar.
And why would that make the definition inadequate?
Well, because now they've taken 2 meals in 6 days, and that's probably not enough. And if they continue it for 300 days, then it's certainly not enough. But
Agreed. Other thoughts about why the inadequacy of that definition?
Yeah, I think the point of the definition is to catch those who are hunger striking without declaring it openly.
Okay.
So it's really more designed to catch the ones who are the silent hunger strikers, which are obviously very few, simply because they want to make a point to someone. So I think you're right. We see all the time where somebody will claim to be on a hunger strike. They'll skip 4 or 5 meals and then eat something and then do it all over again. But usually they give up after a short time. They don't have the strength of character as Dr. Carter's guy who did it for 300 days.
So you guys are getting there. What's the danger of this definition of 3 days and 9 consecutive meals?
water,
Yes.
water or food.
So let's
Yeah.
talk about the water thing, for example. What is 72 hours of no water? What's the result? What's the danger? What happens with 72 hours of no water?
Well, you get to kidney failure eventually.
Right.
You start on that track.
So what I'd say, you're right. What it turns out is that 72 hours, and as we all know, every body is different, every physiology is different. But from the history of hunger strikes across the world, a lot of them outside of our country, 72 hours is kind of the accepted or general length of time that you can stay alive without any water. And so the problem with the 9 meal or 3 day or 72 hour rule is that if they're not taking anything, including fluids, by the time you've defined them as having a hunger strike and kick into gear, they can be dead. So that's the first problem with the 72-hour or this 9-day or 3-day rule. The second problem with it is you guys have gotten there, which is that you can get into a lot of trouble with intermittent meals as much as you can with not eating 9 in a row. I got called into the legislature in Kentucky a few years ago because there was a death in their system, and my notes from that case and from what was in front of the legislature was that he died, and he had been on a hunger strike, but then he started to eat. And custody said he's not on a hunger strike anymore because someone saw him eat from his lunch tray. He's only missed 8 of his 9 meals this week, so he's no longer on a hunger strike. And he died. And not on day 10, but he was depriving himself of enough nutrition for a long enough period of time that he died, but he didn't meet the definition. So not only is the definition a problem for us as physicians, but it's also a problem for custody, because if that's a definition and they don't notify us because they hasn't met the definition, then by the time we get to 72 hours of nothing, he's dead. And by the time we get to a few days or longer of intermittent food, he could also be either seriously injured, harmed physiologically, or dead. And let me ask you then, how, if let's say somebody is drinking fluid, but they're not eating food, approximately how long do they have? Any thoughts? I feel I want I want to be an auctioneer. Do I hear 10? Do I hear?
I don't know the answer. 50?
I hear
100?
50. Do I hear?
I think it depends upon body mass they started
Yeah.
with, what
For
kind
sure.
of shape they're.
Just take the average, 75 kilo male, roughly.
100.
And the question is,
drinking.
how long before they get the
Die.
death, they
Yeah.
die?
Die from day 1, but they're drinking fluid, but not eating. So
Well, I
we
had
talked
a-
about, yep, go
yeah.
ahead.
I had a friend who did that as a suicide from
Okay.
a severe neurological disorder he had, and he elected to do that, and he lasted 28 days.
Huh, okay. So that is on the low side. But
Mark,
obviously,
I think
Right.
the environmental, like depending on which states you are in, if you are in Arizona and it's in July, you probably may die faster than someone in, say, Alaska where it's colder.
for sure.
So that has to be considered, even with the 72 hours, no water, no eating, because you will die faster in Arizona for being out there within 48 hours rather than 72 hours.
Right. But that's with not drinking, Michael. And by
Not
the way,
drinking, but
did you say that because I'm going to Arizona Monday?
I just left there. So
All right. So what I want to do with that information is to remember something called the 72-72 rule. And as you guys are all pointing out, it is very, very dependent on the person's weight and physiology and other comorbid diseases, but it's just a good kind of rule of thumb to keep in the back of your mind. 72 hours without fluid, 72 days without food, roughly. And again, Mike, you gave 50 to 100. It could be anywhere there, but it's just a good kind of idea to keep in the back of your mind. 72 and 72. All right. And one of the other things about definition that you guys brought out as you were giving your examples, and I think, John, that may have come out in yours, is that it's about we're talking about voluntary not eating and drinking in somebody who has the capacity to make that decision. Somebody who is delusional, as your case, other case was, or somebody who is not eating because of an obstruction or because of some other gastrointestinal problem, that's not a hunger strike. Somebody who can't eat a certain food because they're allergic, et cetera, those clearly are not hunger strikes. We're talking about volitional with capacity. But what the third thing, again, is the timing. And what I would all encourage you guys to do when you go home is see if you have a 72-hour, 3-day, 9-meal rule. And if you do, change it. Change it to something that says any significant change in ingestion of food or water should be something that custody notifies you about. Again, once we get involved as physicians, totally different. We're going to use our clinical acumen. We're going to do weight. We're going to look at fluid balance. We're going to look at we'll look at all those other things. But the importance of having a good definition is not because of medical. It's because of custody, that we want to get notified, and we don't want to wait 9 meals to be notified. So I would say the 9-meal, 3-day, 72-hour rule should be gotten rid of, both for defining when somebody is in a hunger strike, and as it happened in Kentucky, to define when it's over. That decision should be our decision as clinicians to say, now we think they're out of danger and we don't have to watch them anymore. And so I think a healthier, a safer definition is any significant change in ingestion of fluids or food is something that custody should say, I need to notify medical and let them make a decision of whether this person is on a hunger strike or not. Or John, as you pointed out, certainly anybody who says declares on a hunger strike, no question, that's somebody we want to watch. I'm talking about the people who haven't declared that they're on a hunger strike. All right, so I'm going to show you a picture. And tell you a little story. So this is a picture of Charles McNabb. And this was in the Spokesman Review, the newspaper in Spokane, Washington, published on the date that you see. And so Mr. McNabb was, at the time, was 50 years old. And on May 23rd of 2003, he started a fire in the house of his estranged wife because he was really pissed at her and he wanted to start a fire. What he didn't know is that his stepdaughter was in the house at the time. He was not trying to hurt anybody. He was just trying to do property damage, but his stepdaughter was in the house. She suffered 3rd-degree burns to her face and neck. She survived. He was arrested and he was found guilty of a certain number of, I think, 6 counts of 1st-degree assault and went to jail. And Mr. McNabb in the jail, the Spokane jail actually, started to go on a hunger strike. And his case dragged on for several months. It was about 6 months, and they periodically took him to the hospital and he got force fed. But he started out at 160 pounds. By the time he came to the prison, so he was eventually found guilty, moved from the jail, Spokane jail, to the state prison system where I was. And at the time I was acting medical director. As you guys know, you wear a lot of hats. So I was a state medical director and acting medical director for this prison because there was no medical director. So I did his intake, history, and physical. And he had gone from 160 pounds when he was arrested months earlier to 90 pounds when I did his history and physical. So he got there over, I want to say it was about 6 months, and obviously was getting in some food in the interim. And so my question, and by the way, the Department of Corrections has a policy, or had a policy at the time, that allows a physician to force feed a patient if they believe that harm is imminent. And so that's the policy at the time. I'm not going to tell you any more of the story right now. And what I want to ask you guys is, what would you do?
So what's the question, Mark?
You're the
you do?
admitting physician. This is the patient, 90 pounds
90
on a
pounds.
hunger strike. And I'll actually, well, no, I'm not going to tell you. What
Yeah.
would you do?
Oh, basic labs first.
You're going to do labs, okay?
Renal function, albumin, prealbumin.
Albumin is several years ago. Albumin was expectedly low. Electrolytes were not all that bad.
Did I understand you to say that there was a policy of force feeding without a court order?
Correct. And yeah, in our state, was you could do it with the policy. There was no need to go to the court. And we're also, by the way, the state of Harper, Washington v. Harper, the Harper hearing, many of you know about that, involuntary psychotropic medications, where the Supreme Court said, hey, you know, if as long as there's a due process, let doctors take care of patients and keep the courts out of it. So Washington's a little bit more liberal that way, but yeah, we had a policy that allowed it. We didn't have to go for a court order. What would you do?
So
Oregon.
he is still living in the medical housing unit, correct?
Say that again, Imhotep?
He is living in the medical housing unit, right?
Correct. He was in the infirmary. Yes, for sure.
Put him in the infirmary, get some labs. I would have a long conversation with him because
Oh.
I'd try and figure out what the hell he's up to and if he's suicidal and what his mental state is. And
So I had a long talk with him. Thank you,
yeah,
Mike. And I came to the conclusion that he was had capacity to make decisions in his own behalf. But I wasn't, you know, this obviously is an important decision. So I had the psychiatrist come see him too. She
Yeah.
came to the same conclusion. I will tell you that his, well, again, I don't want to tell you what his answer was, but what else would you guys do? So he had decision-making capacity. So he met that. He was voluntarily not eating. Decision-making capacity. The time issue is not clearly he was on a hunger strike, and if we didn't force feed him, he wasn't going to eat. I
period.
knew
How
that.
about
So
drinking
often-
fluids? Did he drink fluids?
Oh, he must be drinking fluids if he lasted that long.
Yeah, he was getting. I believe he was drinking fluids. Yes, he was getting some intermittent fluids. Obviously, when he went to the ER and they were force feeding him. But I believe, if I remember correctly, he was drinking fluids, but not eating.
Well, when I was the medical director at Rhode Island, which has got one jail and one prison, and nobody knew what to do, we sent him. The court didn't know what to do, so we sent him to the hospital, and he decided to eat. When Dr. Blanchard, working with me, was the past medical director of the state of Connecticut DOC, and he force fed a guy. And he created a furor in the media and a lot of suit and a civil suit against him, which ended unfortunately.
Okay. So would you? So
those
would
are
you?
tough problems.
You're in a state where you're allowed to force feed based on policy alone without
Maybe
going to the court.
Yeah.
So
yeah,
you would
maybe.
I have a force feed. Do I have anybody else who would not?
Was he ketotic or having any physical complications yet?
He wasn't, but Garth, it was clear to me based on the 6-month history behind him and based on what he told me during the interview that there's no question if I don't intervene, you know, he's going to get ketotic. There was just no question about it.
I sent him to the hospital and put it in their hands.
Well, you know, that's
a
a
punt.
that's
I'm
a
sorry, but that's what.
So
what
the hospital
happened.
sent
Pain.
him. So let me. That's not what happened. But the hospital sends him back and said he doesn't want to eat. He's of sound mind. I'm not going to force feed him. So he's back in your lap.
Oh, that's not fair.
Sorry.
you know,
Sorry, Charlie.
in light of the laws there and the policy there and the patient's condition, I'm heading toward force feeding at this point in time. You've had
Okay.
discussions with them. I don't know about starting IV fluids, which is another alternative, but as I understand it, he was drinking. And I think it's time to do something or get off the pot and force feed.
Okay.
That's where I am at that point.
Thank you for that commitment, Charles. Good. So I'm gonna move on a little bit now that I have your plans. So several years ago at one of our conferences, we had a speaker by the name of Scott Allen. Some of you may know him. In fact, he was at Rhode Island. And Scott, when Scott talks about hunger strikes, he coined this term for hunger strikes called the off ramps, with the concept that we don't want to get to the point of having to force feed somebody if we can avoid it. I think most people would agree about that. And so what can we do between the time that we identify that they're on a hunger strike and getting to the end of the road, what are our off ramps? That's the expression he uses. And I really like that because it's just conceptually very good. So what I want to ask you guys, and maybe this is the heart of the hunger strike management, is whether we decided to let's avoid the question of whether we're force feeding. Let's say we have a few days. What are we going to do with that time? What interventions, what are you guys going to do managing this patient who we believe is on a hunger strike, drinking? Let's also assume that he's drinking, but not eating, or maybe even say he's eating intermittently. So we have a few days, we have a week or two. We're not in a rush. Mike?
Has he gone public, and are there confidentiality issues? Because I might try to get family involved in some way.
So what I'm going to transition the conversation here, and I should have made it clear, is let's forget about Mr. McNabb for the moment. Let's just talk about any hunger striker, because he's going to turn out to be somebody quite unique and different. But just the typical hunger striker, drinking, eating very little, if anything. He's at the beginning of the hunger strike. He hasn't lost more than a couple of pounds, and we think things are safe for the moment. We have a week or two, or maybe longer. What are we going to use? How are we going to use our time? How are we going to manage it?
My
What are the
question
things?
is it still a hunger strike if they're be willing to drink a protein shake or boost?
So I will answer that by saying, for our discussion, let's assume that whatever his intake is of nutrition, assume he's got enough fluids, but whatever his intake of nutrition is, it's clearly not sufficient to sustain life in the long haul. All right, does that set the stage? So if he continues along this path, he's going to run into problems. But for the moment, for the next week or two or three, we think he's not in imminent danger. That's the scenario that I want to set. You know he's on a hunger strike. You know he's serious. We need to. He's on our rounds. How are we going to manage this space? And there are a number of things that we should be thinking of doing that are management issues and off ramps to keep us from getting to that force feeding. What are those things? What are we going to do? What are your skills?
You may have mentioned earlier, but what was his reason for the hunger strike? If you mentioned it, I don't remember.
Well, again, remember, Charles, we're not talking about Mr. McNabb anymore. We're talking about anybody. So what do you want to do?
Well, with anybody, I want to find
out
out the reason that they're doing this.
Yeah.
Very good. Excellent. So you want to have a discussion
wanna
with
get
them and
at it.
understand the reason. That is really step number one. And how are you going to go about doing that? I know that sounds like a simple question, but I really want to make sure that we've got the setting right. How are you?
We would sit around a table with him or her and with someone from the pastoral community. We have a reverend with us who's fabulous. Somebody from the mental health group, somebody from our medical group, perhaps myself, and somebody else from the custody group. And we would have a chat around the table of what's going on, what can we do to help? And I would suspect that that would largely get a response that would lead us to some ideas of how to deal with it.
That's an excellent idea. And I'd like to hear from the group any pros and cons of that approach, or any alternative approaches, or maybe what would be a next step. You had that conversation with the group that you just described. What?
I think, Mark,
Yeah.
while we are discussing this, one of the most famous political hunger strikers was Gandhi.
Okay.
And for some reason, sometimes we may be pulled into the political atmosphere of what is happening. And so that may also be something we may have to consider at the back of our minds as to why, and if we have any influence in making changes for the person.
Excellent. And both of these are really important ideas. We need to understand the reason for the hunger strike, and including custody initially, I think is a very good idea. But the but that is in my mind is, can you imagine a situation where that might not be helpful. In other words, in this second meeting, that including all these people.
Well, you got to pick the right custody person to begin with.
Okay.
Somebody who has a relationship with the inmate on all sides, which, as you know, some people do and some people don't.
So there's two important things that in what you said about just now about that. One is obviously the right person, and the second is building the relationship. And that's what I want to bring out of this part of the discussion, is that over the next few weeks, it's so important to establish rapport. You may have an initial meeting and not get anywhere. Just not get anywhere. And you keep going back. I would encourage you to establish that rapport, that obviously, as you said, to have the right person in the room, but also to keep in subsequent meetings to keep the group as small as possible, so that there's a greater feeling of confidentiality on the part of the patient. And the other component is to try to keep it as the same people. You know, if every day, first of all, it's all of us. The doctor plays a role, the nurse plays a role. I really liked your idea of a member of the chaplaincy playing a role. Sometimes the custody person has the best rapport, and maybe that's the right person, but keeping it to a very few number of people and keeping it to consistent people, so that day after day, he's seeing Dr. Perini, he's getting to know Dr. Perini if he doesn't already know Dr. Perini, and with the hope that at some point, before it's too late, at a week, at 10 days, at 2 weeks, finally he's going to be honest with us and tell us what it really is that's underlying this, if he hasn't told us at the beginning.
One of the other things I missed was we thought we should take him out of his standard environs, which is the cell or the pod, and go down to the library or some very neutral appearing, some neutral seeming geographic place where he was sort of off base, and maybe that's not the right term, but was reasonably, but felt that we were trying to be helpful in a neutral zone.
Right. So I think what you're describing is having him someplace where he's comfortable or she's comfortable.
Yeah.
In their
Exactly.
comfort zone. Very good. In terms of this is information that we're talking about that you're getting from the patient. What information are you transmitting to the patient that's going to be helpful during these few weeks?
I think it's really important they know the policy that in Oregon, similar to Washington, that it's a policy that as their provider, you don't have control over, and how can we work to avoid having to apply it? So, they need to know what the regulations are and what they're up against.
Okay, good. What else? What else are we doing as physicians? What else other information are we giving that might provide an off ramp?
Looking for the purely medical information that they need to have in order to make a good decision about what they're doing, including possibilities of permanent disability, that sort of thing afterwards.
Excellent. So let's dig into that a little bit more. I like that. What are some of those things that you're going to what are those side effects, those harms that we want to make sure they're making an informed decision about their hunger strike, knowing this? What are we going to?
Muscle wasting.
Okay. What else?
Kidney failure.
Good. What else?
What was that?
Kidney failure, renal failure.
Before that, I would evaluate him whether he or she is thinking about a self-destructive path or suicidal motivation, whether it is suicidal or manipulative behavior. What is the secondary gain that this person is looking at?
Okay.
So
I'm
before
going
we
to
go
put
to the medical steps.
very
I think
good.
that's a good point, because I don't know whether he's suicidal or just pissed off at a lot of people. I mean, that might be a difference to how you'd approach that.
So I want to, this is a little bit of a digression from our talking about the clinical information that we're going to give him. But what I want to caution us about, so you've mentioned kind of two scenarios. One is the suicidal and the other is manipulative. I would say that the person who is in the suicidal mode almost comes out of the algorithm because it's no longer, remember we said at the beginning, somebody who is of sound mind, who has decision-making capacity. And I would argue that the person who's suicidal doesn't have that decision-making capacity. If we saw somebody hanging from their cell, we wouldn't stop to ask, have informed consent before we cut them down. We just assume it's a wrong thing, we cut them down. But the other scenario that you brought up is important, the concept of manipulative behavior. And what I would caution you about is that that's a place we get into trouble. All hunger strikers, all ones who are competent, are manipulative at its core. Every hunger striker wants something, and that's manipulation.
I was Republican Army did a hunger strike.
Clyde, you come in broken up. Can you say that again?
Sorry, Doc.
Oh, all right.
You're not coming through. If you want to try going to the chat or try again to say
I think
something,
he may have.
we'll see.
I think he may have inadvertently unmuted himself. That may have been what happened.
Okay.
So one of the places that we've gotten into trouble with across the country and the world with people dying during a hunger strike is when we focus on them being manipulative. Because when that happens, there's a tendency, especially on the custody side, but even on the medical side, to both be angry at them and to brush them off because they're being manipulative. So start off from the premise that they're all manipulative, but manipulative people die from hunger strikes. So they all want something. Some of them want things that are very simple, like I want a color TV instead of a black and white one. Some of them want more serious things like the IRA hunger strikers in the Dublin prisons. But they all want something which is manipulative. So I would say, I don't want to say discount that, but just assume that's part of hunger strike. It's manipulation, and continue to do the things that we're talking about.
Okay,
So let's.
Mark, my question is,
Oh,
does it matter what degree of manipulation to change your approach?
I say that again. Got cut off.
Does it matter, from your estimation, what degree of manipulation they are exhibiting? And does that change your behavior or your approach to them one way or the other?
Two answers. One answer is I use all the information like all of us do as clinicians that we have at our fingertips. But I would say degree of manipulation doesn't matter. Let's understand what it is that they want and deal with that. Garth, what were you going to say something when?
Oh, and in the hunger strikes I've had to deal with, because we have the only intensive management unit in Oregon, I found it most helpful to actually go after what the manipulation is and openly discuss it, and how my views on how it's going to play out with the other players, and just have a nice, open, sometimes repetitive discussion as it evolves over time.
Excellent. So we got a little bit sidetracked for good reason, but I want to come back to the question that I asked a few minutes ago that we started to talk about, is what information are you going to be giving to them? And Mike, you mentioned something, someone else mentioned that you're going to talk about the risks. We're going to talk about risk of renal failure. I think Garth, you said muscle wasting. What are the other specific risks that you're going to share with them that you know are part of the end of the road of hunger strike that you want them to essentially be making an informed decision with? What's that?
Death is the biggie. I mean,
Okay.
that's the end result of the hunger strike, and making the person better aware of that might be of some value, because
Excellent.
Unless there's some degree of, quote, suicidality, I don't think that person wants to die. They want whatever they want, that color TV or something, but it may be an unintended consequence of that person going too long.
Excellent.
Well, I think it's also important to give an accurate description of what a force feeding is, and then it's a one-time event.
Right, John,
Yeah,
and then
I
Mike.
think the issue of telling them they might die, that's what they're threatening us with. I think they know that. I don't think they actually want to die, most of them, but they want to threaten us with killing themselves as part of their manipulation.
You're definitely right. And I like, you said a very key phrase that's important. Forgetting about the people for the moment who are, I don't want to say not serious, but you know that they're a few days they're going to give up. But the people who are really serious about a hunger strike, who have a reason for doing it, John, you said it perfectly. They don't want to die, but they're willing to die. So beyond telling them that they're going to die, which is an important piece, what other clinical things can we tell them about, Michael?
So this is not something that I know a lot about clinically, but it seems to me that they'd be at risk of heart attack, stroke, neurological, permanent neurological damage, whether it's because they're not getting enough nutrients to the brain. I mean, I'd have to go, honestly, I'd have to go like and look it up.
But you're hitting
how much of a possibility of these kind of things, because you wouldn't want to be lying to a patient and threatening them with things that wouldn't really happen. That's why I'm hesitating to bring this up, but it seems like those are all possible outcomes.
They are, and the first place to go look is at thiamine deficiency, because that is one of the most striking effects. And so we're looking at things like diplopia, we're looking at ataxia, we're looking at encephalopathy, potential loss of vision, potential loss of hearing, congestive heart failure, GI bleeding. So those are all things that you can share with the patient for them to realize even before they get to the point of death. And as you point out, Charles, that is sometimes the goal, but realize that along the way, these things can happen and not all of them are reversible. So you could have a GI bleed before you get to, if you're trying to make a point, you want to accomplish something, and all of a sudden you could have a GI bleed and die and bleed out and not get what you're hoping to get. Or you could lose part of your eyesight, or you could have dementia that is not reversible if we don't get to it soon enough. So understand that you're embracing those risks in the course that you're going.
Mark, what about discussing with the patient your limitations as a clinician? For example, the case that I brought up about political motivation by the patient, like in the case of Gandhi. You are not going to be able to provide the independence. And so as a provider, what about discussing fairly and politely and making the patient aware you understand what they are after, but here are your limitations?
I think that's
what
excellent.
about that?
That's excellent. That should be part of the discussion. Now, of course, there's, again, thinking of the IRA members in Ireland who's the only person who could fix what they wanted was the Prime Minister of the UK. You know, the physician couldn't, the nurse couldn't, not even the warden of the prison could. And yes, so Michael, exactly right. They have to understand our limitations. I want to, because of the time, I want to grab a couple of things that you said and translate that into actions. So if we're talking about especially thiamine, vitamin B1 deficiency, and some of its permanent damage, one of the things that we can do as a physician is to encourage the patient to take at least minerals and vitamins and glucose, under the premise that they want to get something, they don't want to die. Why not use our skills, clinical skills, to, I hate to say it, but when you think about it, it's really what we want to do is prolong the hunger strike, which is really to delay death. If we don't tell them about glucose and thiamine and the other things, they're going to die sooner, especially if they're serious about it. But if we say, hey, look, I understand, I don't necessarily agree with what you want, but I understand what you're doing, you have a right to do it. If you would take some tea and some sugar and some vitamins, let me give you some vitamins, you'll be alive longer on your hunger strike and maybe more likely to get what you want and not undergo permanent harm. And ultimately, isn't that what we want?
Mark, that's an excellent point that you just made. Even to the point of, who knows, the person may allow you to start an IV. if you can have a rapport with them and convince them, say, hey, you are still on your hunger strike, but just to help you along, we're going to do the IV, and just to give you some fluids, they may acquiesce and go for it. You never know.
Excellent. And Charles, you brought me to, and I didn't pay him $5 to say this, but you brought me to segued me to the next point, which is one of the reasons for somebody to undergo a hunger strike, and what you would have discovered with these conversations that you've all described, is the coercion. Not all hunger strike is voluntary on the part of the patient. It may not be due to psychosis, but it may be due to coercion on the part of external parties, on part of internal parties. And if you're able to establish that rapport and privately with the patient saying all these things, and the patient says, essentially, help me, I have to appear to be on a hunger strike, but I don't want to die and I don't want harm. And so you can, as long as you have the patient's consent, exactly what Charles said, say, all right, let me quote unquote force feed you with your consent. To the rest of the world, I will keep that confidential. It's between you and me, that I have your consent to force feed you, but everyone else will think I'm force feeding you. And that's an off-ramp that will delay any harm to you. You'll accomplish what you want to, which is to appear to be on a hunger strike, but you won't be undergoing any harm. And so we generally look for face-saving ways that we can keep the patient healthy, and they're not exposed, or they're safe from the coercion. Another mistake that we make, and that it's custody is more responsible for this than anything, is, hey, he's on a hunger strike. Okay, no access to water or food. We want to know exactly, he has to ask for food. We have to know exactly what he wants. How stupid is that? Again, our goal is to prolong life and to avoid harm. And if the guy is interested in surreptitiously taking water or grabbing some food from his neighbor or whatever, why in the world would we want to prevent that just so that we can keep track of it? Well, we want to encourage it. Our goal is to prolong life and to reduce harm. So if he's going to take water, he's going to take food, let him. And if custody has this mentality of let's put him in a dry cell and cut off, tell them how stupid they are, and tell them let the patient do whatever they want, that we can get nutrition in them to avoid the problem. Yeah, Mike? You're on mute.
Sorry, can you just elaborate a little bit on like coerced hunger strikes? Is that really a thing? Is it about gangs, or is it about a group that's pressure? So there's
all of the above.
A half dozen people who are hunger striking in the prison, and nobody can give in. I mean.
So Garth, you're close to California. I don't know how much you followed what happened, but it was back, probably about 7 or 8 years ago, was the largest group mass hunger strike in the world's history, was in the California Department of Corrections. It was there were 2 or 3 waves of it. The second wave was 8,000 people on hunger strike. The other one was several thousand people, the largest experience ever. And a lot of that was gang related. So yes, Mike, it can come from anywhere, and our role is to protect them from it, which also takes us to a point that I don't remember who mentioned earlier, but a change in venue, not only within the prison, but taking them to the hospital by itself can be therapeutic. Taking them out of the prison environment, taking them away from whatever coercion they're under, sometimes just taking them away from us and the rest of the officers is enough for them. There are hunger strikers that just start to eat in the hospital for no other reason that it's a change in venue. I want to put up a slide to think about when you're monitoring somebody, and I don't want to go into a lot of depth, and we don't have time of monitoring somebody in the hunger strike, but just keep track of these 3 numbers. This is amount of weight loss. As long as their weight loss is below 10%, we have time. We're doing all the things. Take your own pulse, as they said in the house of was the house of God. We have time. Less than 10%, watch. Between 10 and 20% is time for us to worry, and I just call greater than 30% wake, as in funeral wake. That's the death zone. So it gives you an idea of how nervous to be. And finally, it's a good time while we're thinking about the off ramps to think about advanced directives and what the patient would like to do, because especially if they get to a certain point where they are no longer able to have decision-making capacity, I'm going to argue that we need to follow their wishes. And how do we do that? We do that with advanced directives. I'm going to segue from that. Again, in the interest of time, we have a few more minutes and we had such a good discussion. I want to caution everybody about the refeeding syndrome. So if we are successful at turning a hunger strike around, hopefully most of you have heard about the refeeding syndrome, which is kind of it's poorly defined. Glibly, we say that what happens is all of a sudden somebody who's not been eating for a long period of time and has a large loss of weight, we start to give them nutrients and they develop hypophosphatemia, hypomagnesemia, hypokalemia. But in reality, we don't really know the underlying mechanism, whether it's those electrolytes that change or something more serious than that. Plus the fact the GI tract for somebody who's been in prolonged hunger strike has atrophied and is not able to accept nutrient. So there's a lot of information about how to refeed somebody who's been on a prolonged hunger strike. And at that point, I think you just need to look it up and familiarize yourself. The simple thing I want you to remember is worry about refeeding in anybody who's been on a significant hunger strike. In other words, they've missed most meals for more than 10 days. More than 10 days and they change their mind, they're going to start to eat. You need to think refeeding syndrome, read up on it, and be very, very cautious in how you start to give them nutrients, including whether the timing between thiamine and glucose, etc. So simple number, more than 10 days, think refeeding and be careful. So I want to wrap us up today on I think, I don't want to say the most important part, but a really important part to me, which is the ethics and the law. And so what I want to ask you is, what is the medical ethic surrounding force feeding of the competent, non-suicidal, non-compromised patient who has made a decision that they do not want to eat to get some gain? What does our profession tell us? Mike?
I think they need to be very well informed and we need to be able to document that information, and I wouldn't do it
Okay, anybody else?
ethically.
I think from a legal perspective, what we
Charles, I'm going to stop you. I'm not going to ask you the legal one. I'm asking you the ethical question. I did that for a reason.
Well, you know, ethically, oh boy, here I go. I'm going to stick my neck out just for conversation. You know, one of the things that we not have to do, but ethically do is take the patient in mind. Look at the patient's wants and needs and try to meet them within our profession. If somebody, it's like assisted suicide, you know, you can't do that. But if you allow them to suicide, I don't mean inmates, I mean out in the world. But we have to do what is within our profession. And I want to say legally, but you won't let me, so I won't say legally.
I'm never going to let a lawyer talk about legality.
But, you know, we have to keep the patient's wishes in mind. That's
And
the
what is
bottom.
that? Excellent. And what is that ethical principle called in the ethical framework, medical ethical framework?
You don't mean like do no harm.
Nope.
What's
There's a
it
more.
called?
Self-determination.
Yep, self-determination or the simple or autonomy. Patient
Autonomy.
autonomy is the first principle of medical ethics. And ethics is different than morality. Ethics is what our profession tells us. We don't get to choose the ethics. We don't have to grapple with, gee, do I think it's ethical or not? For something as like hunger strike, all we have to do is really look it up. And I will share with you that it is that simple with hunger strikes. The World Medical Association Declaration of Malta very, very clearly says that we must, we first of all, we ask if the patient has decision-making capacity. We make sure that it's uncoerced, which is part of decision. Well, it's not decision-making, but it's not a free and clear decision. And are their wishes clear? And if that's the case, the medical principle, ethical principle of autonomy dictates that we must respect their hunger strike, or we must recuse ourselves from the patient's care. That is the ethic. The American Medical Association has adopted that. The ACCP has adopted that. The Nursing Association has adopted that. We don't get a choice. We don't get to reason it.
Okay, then why don't we allow them to hang themselves?
Because, and that's an excellent question, and that's part of the homework that you did when you interviewed them. Is their goal death? If it is, then I agree with you. That's a suicide. But if their goal is to achieve something, but they don't want to die, then that's not a suicide. That's an autonomous expression of free will. And again, you may not like the ethic. There are some ethics in art that I don't like, but it's given to us in the American Medical Association. Well, I said that already. We must respect that desire. Now, Charles, the legal part of it is that the courts, on the one hand, the Supreme Court has said that a patient has that, as long as they have all the decision-making capacity, that the patient has that right. On the other hand, other courts have issued orders. A lot of state and appeals courts have issued orders, not appeals, but that say we can force feed them. And what I want to leave you with is that's the conundrum. That's sometimes the most difficult ethical situation is our ethics tell us one thing, and the law tells us, or at least gives us permission to do something else. Law is not telling us we have to. So I suppose there may be an order that says, Dr. Stern, you must force feed. And when that day comes, I am going to say to the court, I recuse myself from this case because I will not follow a court order that violates patient ethics. I cannot force feed this patient. So
Mark,
yes.
May I
Charles.
make just a quick situation? What you just said, I totally agree with. However, in a correctional setting, it doesn't apply the same way it does in the free world. Because there are many components, the legal, the custody, the family, etc. All of these things come into the formula that may direct us in a way other than the autonomous manner.
See, that's where, and I'm glad you say that, but I will freely say, Charles, that I disagree with you. We've disagreed on other stuff, but I enjoy it. Autonomy is autonomy. And in medical ethics, the bars of a jail don't stop our medical ethics. And there are other factors to take into consideration, yes, but at the end of the day, if this patient has the ability to make an autonomous decision, I have to respect it. So I will tell you, because we're pretty much at time, and that what happened to Mr. McNabb. And I didn't tell you what he told me. What he told me was, Dr. Stern, I'm trying to kill myself. So John, it was suicidal. I'm trying to kill myself for two reasons. Number one is I did a horrible thing. I hurt my stepdaughter. That wasn't my intention. And the court gave me whatever it was, 10 years in prison. That is not an appropriate, serious enough sentence for what I did. The sentence for what I did should be death because it was horrible. And he felt tremendous remorse. And he said the second reason is, I don't remember starting the fire. I don't say I didn't do it. I just don't remember. I'm sure I did, but I don't remember it. And he said, so Dr. Stern, what's to prevent me from starting a fire here in the infirmary and killing, now actually killing rather than just burning, but killing some other people? I don't know any way of preventing that because I don't remember doing it. So the only way I can protect others is by killing myself so that I don't harm others. And I got to tell you guys, I thought that was one of the most rational things I'd ever heard. It was well reasoned, and it was part of what made me think he has decision-making capacity, and so did the psychiatrist. However, I had this policy in front of me, and Charles, since I was a good minion, I followed the policy. I wrote an order to force feed him. He went through a couple of force feedings and said, "Hey, uncle, I know you guys have the power. You can continue to do this, and so I am going to eat. It's not voluntary, it's coerced, but I'm going to eat." He sued us, went to the Supreme Court. He lost. And so what I'm going to say to wrap up is, in retrospect, this was 20 years ago almost. I believe I did the right thing for the wrong reasons. I believe I did the right thing because he was suicidal in effect. He was trying to kill himself. And even though he was rational and gave me good reasons, it's John, suicide. And whether you do it over 6 months or whether you do it over 60 seconds, it's suicide. And no question, I would have cut him his rope. So why wouldn't I force feed him? And so I should have force fed him, but I should have force fed him because he was suicidal and therefore almost by definition doesn't have decision-making capacity. Instead, I force-fed him because there was a policy that said that I could, and that was the wrong reason. That policy violated his autonomy, and so I did the right thing for the wrong reason. On that note, again, I'd love to stay for another 2 hours, but I want to respect the time. Any parting questions or thoughts?
Mark, that was great. I enjoyed it. That was one of the fastest hours I've seen in a long time. Thank you very much.
Yeah, I think this is a great model for future talks. We've gone a lot the way of pure didactics, and this is much more useful. And I think that we'll get people in here who just want to network about the topic. I'd really like to see more of this and less didactics. Mark, I'm very appreciative for your approach and for you taking the time to be with us. And I am 100% clear that we've got that the profession has a wonderful resource now in this. Even though we didn't get as much attendance as I would have wished, I think we've got a
We had the
great
important people here, Mike.
I'm with you, brother.
Great job, Mark.
Appreciate it.
I think
Thank
most
you,
of you
Mark.
know how to get me, but that's my contact information. If also practically, there's one of the state medical directors who call me periodically every time he had a tough hunger strike. So I'm glad to do that for you. Thank you, everybody. Michael, thank you for inviting me, and
Thanks,
Thank you.
Dr. Stern. Great job.
Thank
I
you.
also have my contact information if you have ideas. So thank you.
wonderful
See
evening.
you in
folks.
September